Welcome back to the Derm Club podcast. You might find it surprising that dermatologists prescribe more oral antibiotic prescriptions per clinician than any other specialty. We know that antibiotics are very effective for treating dermatologic disease like acne or rosacea. But as clinicians and dermatologists, we have to always be concerned with antibiotic resistant infections that our patient can develop. To dissect this important topic and how we can steward the best approach for using antibiotics in dermatology, I welcome Dr. James Del Rosso, who founded the Scientific Panel for Antibiotic Use in Dermatology in 2005, which has continued to guide clinicians on optimal antibiotic use. Dr. Del Rosso's current role is Senior Vice President of Clinical Research and Strategic Development at Advanced Dermatology and Cosmetic Surgery at the nation's largest dermatology practice. He is a recipient of a Lifetime Achievement Award by the American Academy of Dermatology for his contributions to the field. Formerly, he was a dermatology residency director, a past president of the American Acne and Rosacea Society, the American Society for Mohs Surgery, and the American Osteopathic College of Dermatology. Additionally, he's a contributor to dermatologic books, including a manuscript in dermatologic clinics called Antibiotic Use in Dermatology, an issue of Dermatologic Clinics. Dr. Del Rosso, it is a delight to have you on the Derm Club podcast today.
Great to be here. And I was thinking, did I really do all that stuff? Man, I needed to get a life, huh? So anyway, it's certainly great to be here. And it is, I think, a very important topic that I've spent a lot of time reading about, working on with others. And it's a pleasure to talk about it.
Thank you so much. So let's begin. What does antibiotic resistance mean?
So, the antibiotics, when we're talking specifically about antibiotic resistance, we'll limit the discussion to medications that can be applied or taken systemically. And in dermatology, we use both of those, but we use a lot of oral antibiotics. It's not very often that we're giving patients, injectable antibiotics, though that might be the case in hospitalized patients or in rare circumstances. So we'll focus on, giving oral antibiotics or giving topical antibiotics, because I think sometimes people focus on the oral and they forget that you can get resistance, important resistance patterns with topical antibiotics, and those have been described in the literature. So I think the way to think about it is when Fleming got up at the podium and talked about getting his Nobel Prize for discovering penicillin, he had already identified resistant organisms because the bacteria figure out ways to, when they're exposed to antibiotics, to work around them. They're pretty smart. They have a lot of genetic machinery, either gene mutations or portions of genetic material called plasmids that they can transfer to other organisms. When bacteria die in the environment, they release these different snippets of genetic material that carry resistance patterns they pass it on to other bacteria that can pick them up in the environment. Not necessarily the same genus and species. They can pass this. I like to say bacteria are promiscuous. If there's going to be somebody that's interested in taking the genetic material, they're going to find them. But they do estate planning. When they die, they pass it on. I mean, I'm still waiting for some of my previous relatives to pass on some money to me. It's never money. It's always bad genetic material, like gaining weight or whatever, or what. But anyway, but seriously, they do this. So bacteria have a lot of mechanisms for where they can circumvent antibiotics. So as we get a new antibiotic and we're excited about it, it has this ability to diminish or eradicate bacteria, but over time the bacteria figure out ways. Some of the bacteria figure out ways to get around that, and then we run into resistant strains and see that patients are not responding like they did previously, because let's say for a treatment of an infection specifically, and then we'll get into a little bit more about what the significance of that is. But that's what bacteria do, and that's true with topicals, right? When you give somebody a topical, a triple antibiotic ointment, even, we don't think about it, you get resistant organisms to some of those those agents. So we might think, oh, we're not giving neomycin or bacitracin systemically, but sometimes these organisms package multi-resistant genes and they can confer resistance to other antibiotics. Over time, they've figured out how to, it's like if you drive up to a Burger King or a McDonald's, maybe you don't do that, but I do sometimes, and you get the meal and it packages a few different things as opposed to getting only the cheeseburger or only the Coke or whatever. They package and they package multi-resistant patterns nowadays, and that happens quite a bit with systemic and oral antibiotics.
It's interesting because I feel like there's a big move away from like bacitracin ointment, neomycin ointment, but that move away is because of contact dermatitis. But I wonder if that, as a result, it's really helping us build up not having that resistance.
I mean, your point is spot on, Hannah, and so we can start by an area where antibiotics have been used reflexly. We have a patient, and we're not necessarily talking about a patient that may be truly immunocompromised or there's potential risk of infection. It's a wound that's not necessarily a clean wound. It's a patient that is immunocompromised and you're performing a surgical procedure, maybe a prolonged surgical procedure, at least invasive in the skin. We're not necessarily just doing a superficial saucerization or shave procedure, or we're having more invasion into the skin, and you think maybe it's smart to put this patient on an oral antibiotic. They have cardiac heart valves, or they've been told by another clinician you need to take antibiotics, and you're respecting that, even though those recommendations change around surgery. For years, we've reflexly given patients after we do an office-based procedure or even an excision and repair or a Mohs surgery with a repair. We give patients an antibiotic afterwards. We give them cephalexin or whatever somebody wants to give them, and we know now that that's not really helping the majority of these patients. And we have them apply an antibiotic ointment with bacitracin, neomycin. And we do that thinking that we're actually reducing the risk of infection. But if it's a clean wound, especially with the superficial or a limited procedure performed in the office with just the basics of prepping the wound, and cleaning the skin, and wearing gloves and all the basic things we do to try to prevent infection, the infection rates are extremely low. But if we have patients applying a topical antibiotic, they're definitely with bacitracin and neomycin. If you get a call a couple of days later, oh, it's red, it's inflamed, I think it's infected, I would go as far as to say more than 99% of the time when they come in, they have a contact dermatitis and they don't have an infection.
Right.
And so that's brought attention to the fact that, are we really doing anything in the first place in preventing infection? And we're exposing patients to contact dermatitis, which they don't want, we certainly don't want to see. And we're not talking about to the bandage around the wound, we're talking about from the topical antibiotic. So around the wound itself, not just the periphery where the adhesive is, we're seeing this contact dermatitis. And that's brought to light actually looking at the infection rates. And if you actually look at the infection rates in some of those cases, if they're utilizing a topical neomycin, for example, they're going to select out, it shows that the infections tend to be selected out sometimes with organisms that we're not so happy to see, because the organisms that would typically be a problem, like staphylococci or streptococci, which are easier to manage, even topically in some cases with things that we have, are not what's happening. We're getting other organisms, sometimes gram-negatives, that are more of a hassle to treat. So we can even be creating some of these infections with organisms that we don't want. So by and large, the majority of these wounds, especially clean ones with superficial procedures or short procedures, even with repairs, topical antibiotics are really not doing anything, and either are oral antibiotics, other than exposing the patient to the antibiotic, which they may be fine with. They don't have any adverse effects, but now you've exposed their body And let's just say, even just start with the GI tract microbiome, right? Um, just the GI tract bacteria. Microbiome can be a confusing term right now. GI tract bacteria are being exposed, and you're selecting out resistant organisms, and they don't necessarily create a consequence in that patient, but these resistant organisms end up in the environment. Not everything that's in the gut stays in the gut and can
Right.
be transferred a variety of different ways, and we wouldn't know that, right? We wouldn't know that we created a resistant organism that happened in myself, from myself, let's say, and I go visit somebody, and now I've transferred that through hand contact or whatever, to someone else, and they have a problem. How are you possibly going to track
You
that?
don't realize the impact is so much
You just
greater.
don't realize it. So the what Jim Layden, who I've learned a ton from over the years, Jim Layden, from, known as an acne guru, but he's really extremely knowledgeable in many areas of dermatology. He called ecologic mischief. So when we prescribe an antibiotic, and we can take this now to acne, right, or acne or rosacea, where the majority of what we prescribe are a tetracycline, either doxycycline, minocycline, or now sarecycline, which has a more narrow activity, not as much against gram negatives, but still we're prescribing antibiotics. And we're using these not to treat an infection. We're using it to treat an inflammatory condition where in acne there's bacteria involved. In rosacea, we don't necessarily believe that's the case, but they're being used for anti-inflammatory effects. Right. And so they're used for a longer period of time. They're just not used for 10 days or 2 weeks to treat an infection, let's say a localized MRSA infection or whatever, for a short period of time. They're being used for months. And it doesn't take very long to select out the resistant organisms, and we have data on that. We select out group A streptococcus, that could potentially be a pathogen in the pharynx. That person doesn't necessarily get that infection, but they cough on someone else that does, right?
That's a warm.
And even in this modern times of masks, organisms get out there. Organisms are tricky, and they're smarter than we are. They figure out how to survive, right?
Yeah.
Um, I think if the Earth ever exploded in a big bang, um, there'd be fragments that end up somewhere else where there'd be organisms, bacteria, fungi, viruses that live on when we would be gone. They're going to survive. They're going to win that battle one
Yeah.
way or the other. So that's how a lot of this happens. So now let's put ourselves in the position. It's easy for Jim Rosso to say that, right? Or anybody sitting in a boardroom or on a Zoom call or whatever, pontificating, hey, you need to use less antibiotics. And this was never really directed at dermatology. That's why I started with others, that scientific panel, because they were changing mandates, the CDC and the FDA, some years back, and even changing package inserts to say 50% of the antibiotics shouldn't be prescribed. They're talking about the patient that comes in the wintertime that has a viral upper respiratory infection, but they're getting an antibiotic. Well, and it's not always that easy to differentiate. So I don't fault those clinicians for doing that, right? But there are patients that are getting antibiotics that don't need
Especially
them.
when you have a patient who comes back in 3 times and they're saying, Doctor, my cold isn't going away. At that point, you say, okay, I'm going to give you an antibiotic because that's basically what they want.
Yeah, and there may be times you get, cultures or things. It's surprising to me how few times people get bacterial cultures and sensitivities nowadays. Sometimes it's cost, but in the scheme of things, finding out the causative organism, or trying to, could never be faulted. But if you don't, and it ends up being a situation where there's a consequence and you didn't, oh, Dr. Kopelman, have you ever heard of a bacterial culture and sensitivity, and why didn't you get it? Doesn't Koch's postulate say you should always find what's causing the infection? I could just hear that in an environment that none of us would want to be in. So if you can find it, go ahead and do it, right? But in acne and rosacea, we're not necessarily doing that, but we're prescribing these agents for their anti-inflammatory effect. We are selecting out resistant organisms. It's a fact. it's just a fact. It's a microbiologic fact. It's not something we can say that just because we don't agree with the data doesn't mean the data doesn't exist. I think it was Huxley that said that. Just because we ignore the data doesn't mean the truth of that data doesn't exist. So when we prescribe antibiotics, we are creating resistant organisms. Now, in the case of acne, um, sometimes we're in a situation where full court press topical therapy is not getting the job done, even if we feel the patient is compliant. And so now we're in a situation, okay, I can put you on a course of one of the oral antibiotics. Let's say I'm trying to even be more narrow spectrum. So I say I'm going to give you oral sarecycline, and over a period of time. Or if I use doxycycline or minocycline, those have been around a long time, and they work and for acne. But there are resistant organisms that are going to emerge, and I know that. So I want to keep that down to as short as possible. But it's not always that easy to do. The patient takes it for 3 or 4 months with the topicals. You adjust the topicals. They're compliant. Their acne is significantly better. And then you stop and they come in 2 or 3 months later and the acne is back. So then the guidelines, some of the guidelines will tell you go back to the last antibiotic that worked. But they're on this antibiotic cycle, this roller coaster, repeatedly. And at some point, I think you need to try to put a stop to that and get them to consider, if they can, and most people can, oral isotretinoin. There's baggage with that you have to go through, but that's going to give them the best chance of getting prolonged benefit and being able to get off antibiotic therapy and have a limited time of exposure to a medication that gives them long-term benefit. That doesn't happen with anything else we have, So I think we have, for me, my threshold for trying to get people to oral isotretinoin, it's slower. And I talk to them about that. If they don't want to do it, then you have to deal with the other options. But if they're taking antibiotics, you're going to select out resistant organisms. So I'm waiting for what I think your next question should be. So I'm challenging you to see what your next question
I don't
comes up
know. No, I'm curious if you ever, it sounds to me like you are willing to kind of skip the antibiotic step and go from these topicals, maybe adapalene or even antibiotic topicals like clindamycin, right to
benzoyl peroxide,
peroxide,
tazarotene.
the oral, the typical is first we're going to try these topicals, then we're going to try if the topicals don't work and the BP wash doesn't work, we'll put you on we'll try out doxycycline or minocycline. If that doesn't work, then the last resort, typically because of the label and the associated with isotretinoin, that's kind of been the last resort. Do you seem to kind of skip that oral antibiotic step?
I don't necessarily. In the back of my mind, I'm thinking I wish we had something else to fill this void, but we don't. We really don't. Now we really have to focus on that full court press with the topicals and really be sitting down and getting the patients to do it. We have better formulations of topicals, so the irritation should be less, but the patient has to have access to them. So sometimes cost and access are issues that come up. And benzoyl peroxide for the face, I prefer a leave-on benzoyl peroxide. I think a lot of the washes, we have no data on whether they're actually doing anything. On the trunk, we know that just putting a benzoyl peroxide, even high concentration on the trunk, doesn't reduce the C. acnes, right? If you just put it on and wash it off, you need a contact time and a high enough concentration. So if they're using a benzoyl peroxide that I know is actually getting the job done, it's reducing the emergence of, we know, resistant C. acnes and probably other organisms in where you're applying it. But if they're taking an oral antibiotic, it's going places where they're not necessarily applying the benzoyl peroxide. So we say, use benzoyl peroxide to reduce resistance. That's great, but that's only where they're applying it, right?
What about everywhere else?
What about everywhere else? And if you're treating the face, it's getting to the trunk and it's getting to other body locations, which may have lesser organisms, but you're still selecting out resistant organisms. So it's a quandary, and it's not one that I've always said, and maybe people that are reading the articles that I've been a part of are thinking, "Who the heck is this guy?" He's telling us that we're wrong. No, I'm really not telling people that they're wrong. I don't feel comfortable in that. As clinicians, we have a lot of challenges, and I'm certainly on that same page. But just give it consideration that you're taking the time, some time to step back and say, do I really need to be using this oral antibiotic? It's an inflamed ruptured epidermal cyst. The chance of it actually being, let's say, a staphylococcal infection is extremely low. And so why don't I IND it? And why am I automatically putting the patient on a course of doxycycline, for example?
Mhm.
And, or I see a leg ulcer and I'm automatically putting them on an oral antibiotic when that patient, that's not necessarily going to help. Good local care is going to get the job done. So I think those are the situations where it's important for us to, or after a shave biopsy or a saucerization biopsy, do I really need to be using this topical antibiotic or even oral antibiotic? So I think we can reduce the the times that we prescribe and oral and topical antibiotics and the durations that we're using if we think about this, and sometimes can come up with other options, right? But I never want to be saying, oh, look, what you've been doing for the last, you know, so many years, bad boys and girls, that
Yeah.
wasn't the right thing to do, because I don't necessarily believe that. Everybody's doing the best with the information they have at the time and the options that they have available to them at the time.
Yeah,
But sometimes no antibiotic is a better option. And
right.
that's basically what I'm referring to.
I recently was working with a clinician and a patient came in, they had a biopsy or a skin cancer removed on their leg. They came in like a week later. It was red. Was not warm. There was no sign of infection, in my opinion. But the clinician quickly slammed this patient because he was complaining that it was red with 3 antibiotics. And I was a bit taken aback by that. And recently I just spoke to Dr. Kersner at University of Miami, who is a wound care specialist.
I
And
know him. He's fantastic. He's
so
fantastic.
everyone should check out my podcast with him. We discussed how he really has moved away from prescribing antibiotics, and he really holds them closely to to his heart and doesn't give them out until he says, okay, this patient is now has a sign of infection, they need antibiotics. He has proven that you can actually put, first of all, he says the most important thing is venous leg circulation. So give them compression stockings. That might be one of the reasons that they're getting so much redness around the area. And that's more important than slamming them with 3 antibiotics when you're about to create a ton of resistance. And in addition to that, I just want to mention one other thing that he thought was important that we talked about earlier, is when after doing a biopsy or a removal, if you just simply put, people are starting to move away, as we said, from bacitracin and neomycin, and a lot of people are starting to use Vaseline. So he says you can even have enough moisture with the proper bandage, because if you leave a bandage on for a week or a couple of days, that under that bandage, if it's bandaged properly, it creates enough moisture and you'll actually have the same outcome in healing. So I just wanted to mention that. But in terms of going back to acne and rosacea, specifically acne, do you feel that it's really necessary to put a patient on doxycycline or minocycline for 6 months? When you tell a patient, I'm going to give you an antibiotic for 6 months, they're in shock that they will be on an antibiotic for that long. Is that timeline necessary? And what are
I
your
don't.
what
I
are you
don't think I would strongly discourage giving a timeline, because we don't know if it's going to be 6 months. We
right?
don't. I would. The way I would say this to them is, I think your situation right now, one of the options we have to try to help get your acne under control, and you need to be compliant with all the steps, right? And I ask for 3 months. I tell them, but I don't tell them necessarily a a an absolute duration that they're going to be on. I'd say I need 3 months from you to be really consistent and compliant with everything I'm asking you to apply and everything I'm asking you to do, unless you're having what you think is a problem with it, the side effect. And if you miss any one of these things I'm asking you to do, you need to give me more time. Because if this is going to work, it's going to be everything working in combination, right? The house is never going to get fixed if you have the person that puts up the drywall, but the electrician never comes by, right? You need everybody working together. In this case, at the topical retinoid, the topical, right, and try to work with them on how to make it as compliant as possible and the least frequency of application of the medications as possible, so it's doable. And so then I'm telling with them, my goal is to get you off of this oral antibiotic and try to maintain you with the topical treatment that sometimes does it and sometimes doesn't, right? And there are studies to show that it can hold some of the patients, assuming it assumes they're using the medications and study the way they're supposed to. In the real world, they're probably not. But the more compliant they are, the better the chance they're going to get. And that I don't want to have you on this oral antibiotic indefinitely. And that's our goal, right? I am selecting out resistance in the beginning. I know that, but I'm trying to reduce this entire duration. Or we can talk about, you know, other options, right? We can talk about isotretinoin. We can talk about potentially some devices, some better devices that people might have in a practice and be able to show some benefit. Those tend to be out of pocket, so that becomes a consideration. Cost is always factored in there, but I discuss with them up front. And I try to really get as much out of the topical therapy that I can, and try to get to them the best agents that they're more likely going to be able to use, which is not always easy in the access world. But in an ideal world, you can often get these patients significantly better. I feel that when patients actually use and do what we ask them to do, the majority of them get significantly better. And if they're not, then I have to be thinking what else is going on. Is there something dietary they're doing, something they're ingesting that's androgenic, or something they're injecting that's androgenic, or um, have polycystic ovary syndrome or something, in a female patient. I have to think about those other things if they're truly refractory. And that goes back to another question. I mean, I had a woman that was about 23, 24 years old that had been, battling acne and hassled with acne and going round and round and round and getting some better and not really better. And she didn't really have any of the history, a lot of the history that would make me think, oh, she has an underlying endocrine situation, but she did. I said, you know what? Has anybody ever tested you? She wasn't on oral contraceptives or something that would interfere with the testing. So during the menstrual period, I got her DHEAS, I got her free testosterone, total testosterone, the basic assays, and she had elevated levels, and she ended up having polycystic ovary syndrome. They don't all come in with the classic textbook picture. And so, offering something different that wasn't done before, and then I could avoid antibiotics. Or if I decided to use them, using them for a short period of time. So we do have some of these other options in women. We have spironolactone, we have oral contraceptives if they're willing to be on those, and also trying to stop pregnancy and they don't have risk factors, they're not older with risk factors for DVTs and things of that nature. Everything we select, we have to think back, what do we have to do to make sure we're not getting, the patient into more trouble side effect wise. But it's not easy. It's easy to pontificate what people should do, but it's not easy to actually do it, because there
Yeah.
are these situations that come up.
I find that there's these great alternatives like oral contraceptives, spironolactone, but I have found that many dermatologists are very hesitant to prescribe oral contraceptives because they just don't feel comfortable like managing that. Because I guess obviously it's influence on their menstruation. But I think that if we could educate dermatologists and make them feel more comfortable with prescribing oral contraceptives, we could possibly move away a little bit from prescribing oral antibiotics in such a rush.
Well, if you don't want to prescribe oral contraceptives, there are certainly other people that can assist in that regard. And I've done that, and other people have done that, because I think as dermatologists, we don't want to get the phone calls. Oh, I missed 2 of my pills. Am I going to get pregnant? We don't want to deal with the other side of that coin, because that's not what we do. And I think I don't fault dermatologists for not wanting to get into areas that they don't do regularly, but you can still get patients to be seen by primary care or whoever. And the dermatologists that feel comfortable prescribing them can. I use a lot more spironolactone, and I use spironolactone without oral contraceptives. And in many of those patients, that it works extremely well, and we can keep them off of oral antibiotics. But focusing this back to, so kind of, we're encouraging people to be more thoughtful and in their oral antibiotic use. So I'm one of those people, and I say, okay, I've done that. Does that really have impact? Is if we change the prescribing of oral antibiotics in a community, a specific oral antibiotic in a community, is it going to reduce the emergence of resistant organisms that have developed to that antibiotic? And the answer is yes, but it can take some years.
Mm-hmm.
Right? It doesn't happen overnight. This has been done in a few countries outside the United States, Scandinavia and Japan, I could think of, where they weren't necessarily looking at dermatologic treatments, but they were looking at macrolides and whether you have emergent resistant pneumococcal organisms or group A beta hemolytic strep, or organisms that might cause pneumonia or something that you're trying to reduce the resistance. I mean, this is far reaching. This is way beyond dermatology. It's patients coming in with pneumonia and needing to get treated, or they're going to have a significant problem, and we don't want to prescribe an antibiotic that they're resistant to and lose time, right?
Right.
you know so these things have been looked at, and they are able to reduce the emergence of resistant organisms to a specific antibiotic or a class, if the bacteria are behaving in a, or I'm sorry, the antibiotics are working in a similar fashion. With some classes, you can have a methicillin resistant staphylococcus strain that's responsive to minocycline but not doxycycline, even though in the same chemical class. So you can have those differences, but there are some class effects that occasionally come up. So if we reduce the antibiotic use, because we might be thinking, oh, just me as an only dermatologist here is not making a difference, but collectively we can make a difference. There was a very interesting study, and I can't remember exactly what it is, but it's referenced in one of my scientific panel articles, where they looked at patients coming into the emergency room. And I learned this from a microbiologist, a great microbiologist who's very attuned to all of this, including dermatology, George Zanel, from Canada. Great guy for you to interview for a podcast, quite frankly. Very knowledgeable. This study, I learned about it from him. The patients would come in and they would look at what antibiotics they were taking for whatever reason they had taken within the last 3 months. And then they had pneumococcal pneumonia. And then they looked at the resistance patterns to pneumococcus. You might be thinking, how does this relate to dermatology? Well, it can in a similar scenario with us, depending on what the infection is and what patients have received, right? And so if the patient had gotten azithromycin in the 3 months before, or quinolones even more, right? There was certain quinolones like ciprofloxacin within the 3 months before, or levofloxacin, their resistance of those pneumococcal resistance to those antibiotics was exponentially higher, which means that you wouldn't want to pick that antibiotic as your first treatment for that patient.
Right.
Knowing that history, it selected out those resistant organisms, and that organism ended up being problematic. So it does make a difference. So I can't give you all the answers of exactly in every situation what's the best thing to do, but just try overall to reduce the antibiotic use when it's not needed, shorten it, put some deadlines on it with acne patients and say, okay, we can't keep doing this. It's only so many cycles of antibiotics that we can use. Um, and and in the case of rosacea, we have sub-antibiotic dosing of doxycycline. I would always try to do that if I could, right? Because it's not zero in selecting out. You know, it's not that it's impossible not to have a resistant organism, but you don't get this proliferation that emerges that you see with antibiotic dosing. So that's an option that some people have had trouble wrapping their head around, but it does reduce the anti-inflammatory effects and circumvents a lot of the resistant effects. That's how many people would raise their hand? Would you like to be on an antibiotic if you didn't need it? I've asked them in several lecture halls. I've never had one person raise their hand. Oh, I'll take it, but I don't need it, but I'll take it. So that's what we're trying to do. Mhm.
Mhm. I mean, it sounds like based on that study you just mentioned, it might be beneficial to take a better history and ask the patients, have you been on any antibiotics and which ones have you been on in the last 3 months?
Or 6 months in the case, whatever.
I mean, it's
It is. It's important to know,
yeah,
right?
because it sounds like that would make your decision about which antibiotic you're going to put them on. You want to make sure you're not going to put them on the same one.
Right.
So,
Right. And at least in that scenario, that's what they showed. And I don't have the data in other situations of skin infections or other type of infections, but I at least can extrapolate in my mind that this makes sense, that I could have selected out resistant organisms and I don't want to encounter that problem with what I'm prescribing.
right. So, what can dermatologists do? You mentioned some of the things. What can we do going forward to prevent this from happening? What's the solution? And what is your take home message for clinicians and the public? I mean, are we running out of antibiotics? And do we have to keep creating new classes of drugs? Is that even realistic?
It's very hard for that to be realistic. You know, that it's certainly going to be done, especially when you're treating patients with serious systemic infections in the hospitals. That scenario, when we read about deaths related to antibiotic resistant organisms, that's usually the scenario we're talking about. Hospitalized patients that get multi-drug resistant infections, and that is a problem. But we do have a problem out in the community to try to maintain the effectiveness of our antibiotics. And so what dermatologists can do, the first scenario would be a peri-procedural. Okay. In our office, all right, patients having saucerization, shave biopsy, they don't have any of these risk factors that the American Heart Association is saying, okay, this is where you need prophylaxis. And those have been honed down, right? Right. And those have been those are more narrow. It's just a patient coming in that is not significantly immunocompromised. It's a clean wound. You're doing a saucerization biopsy on a forearm. No need to give a topical antibiotic or an oral antibiotic around that. There's pretty good data to support that, and just start doing that. Give the patient. I appreciate what Dr. Kirstner said, but I think most people are going to want to put something on. It's very thin layer, not gobs. And I've watched some of my staff sometimes, they take a cotton tip applicator and they put a big glob of petrol. Most of that is just macerating the surrounding skin. They just need a very thin layer, and they put their bandage on, whether you're using, petrolatum or Aquaphor, CeraVe healing ointment, whatever. Basically, those particular formulations. The fewer allergens, the better,
Right.
obviously. So, you know, that's all you need to do, and follow that, and do that for a while. If you haven't been doing that, do that for a while, and that in and of itself is going to reduce some of those organisms, especially if you're avoiding the oral antibiotics.
Right.
Remember, when we give an oral antibiotic, there have been several studies to show that the resistant organisms that are selected out in the GI tract after the antibiotic is stopped persist for several months. And if you look at the entire microbiome in terms of the bacteria that are there, the resistant patterns last for months. They don't return to baseline, you know, the baseline microbiome very quickly. So you are selecting out these resistant strains. And so now we get to acne and rosacea. With rosacea, I think we have, excellent topical agents we can use to reduce papules and pustules. And we have the other topicals, alpha adrenergic agonists for the vascular erythema. And if we want to use a systemic therapy, I would encourage subantibiotic dose doxycycline, either the 40 milligram modified release or the 20 milligram given twice a day, where compliance can be a factor, because if they miss a dose, it's not going to work as well. And give that a try in combination with the topicals, right? Hit it harder up front and then get the patient under control. So we have that option. If you have a patient that doesn't respond to that, right? And remember, we're giving a low dose. So regardless of what package inserts say, don't have patients taking with milk or calcium supplements or metal ion, zinc supplements, iron supplements close to when they're taking that, because it'll bind some of it and they'll get less. And you're already giving a low dose, so less than the already a low dose might be contributing to treatment failure. If you were given 200 milligrams a day, an antibiotic dose, that might not make a difference. Right.
You want to make sure you just maintain that therapeutic level.
You try to maintain that therapeutic range that you need that agent to be at. So I think that's a good place to try. With acne, really the full court press of topicals, and really try to get people to do that. If you are putting the patient on an oral antibiotic with topicals, give a time frame and really try to stick not going past that time frame and think about other options. If you know the severity right up front is that this patient is very likely going to be going on oral isotretinoin, I would try to get to that sooner if you can, because the patient's going to be better off in the long run, right? Well, there's great studies on treating severely inflamed patients with severe inflammatory acne that have some nodules, not loaded with nodules, but we're utilizing topicals and orals, right? We're utilizing doxycycline with potent topical retinoid, benzoyl peroxide, whatever the case may be. In 3 or 4 months, we get them significantly better, but then they're going to have to stay on that. Right. And so we're back into the same situation. So I try to have that discussion and follow that as closely as I can. And then treating infections, you give it, if the patient has an infection, don't just be treating something because you presume they have an infection. If you make a clinical diagnosis that this is a cellulitis and it's suppurative and it's infected, and you want to get a culture and then start something, I would encourage people to culture. I think too often they don't, right? But if it's purulent, culture it. Somebody might say, "Oh, that's too expensive," right? But I don't think you can ever be faulted for trying to find the cause of an infection, right? And then you give what you think is the best, and then if you have to change that antibiotic and use it for that course of treatment, and then be done. And these courses of treatment may be shorter than what we typically follow, because we have to remember some of these drugs, they were just studied X number of years ago and they put a duration on it and that was it. It's not like they looked at different durations. But you don't want to shortchange the treatment.
For 10 days. And then they said, now they're saying, well, why 10 days? And it was just because that was the timestamp they put on it. It was not for any good reason.
But we don't know what else to do because we don't have all that data. So you pick that time, you get them on it, you make sure they're better, and make sure they're doing the local care to the wound. That's also very important. If you're keeping it all soppy and crusty, that's not going to do as well as if patients are actually properly taking care of a wound, right? If they have bacterial folliculitis, you think it's bacterial folliculitis, you treat it for that appropriate time course. And if it's shrunk and it's on the body, I would have those patients utilize a high concentration benzoyl peroxide cleanser. Try to keep it on for 10 to 20 seconds or 30 seconds and then wash it off, right? We know with the 9 to 10% foam, there was a branded formulation. It's the only one studied on the trunk. You needed about I think it was 2 minutes of contact time and then wash it off. So you try to get them to do that the best you can. Whether they're going to stand around for 3 minutes before they shower something off could be a little difficult, but put it on, brush your teeth, and then go into the shower and wash it off. If you can get people to do some of this stuff, that's not always easy. But there are things we can try to do. But that means we have to be cognizant of it and be thinking of it. If we're not, we're just reflexly going to I'm showing my age like I'm writing a prescription, right? But we're typing the prescription in the EMR now, right?
Well, thank you, Dr. Del Rosso, for educating both the clinicians on how to prescribe antibiotics more judiciously and for teaching patients how to use them to the best of their benefit. It's so important. I think this topic is only gonna get more important as the population ages and as we grow. So thank you for your time and the work you're doing.
Well, I'm very happy to do it. I do it as a clinician. I'm not a basic scientist. I'm not in the lab. I'm not at a university center. Having the ease of going down the elevator to talk to the microbiology person or whatever. But we try to get as many people together to give their best knowledge that they have and just stay aware. We don't have all the answers, but we can at least make attempts to try to limit the antibiotic use and use them more judiciously when we're using them, right? If we didn't have antibiotics, some of us might not even be here to talk, right? Because they've obviously saved a lot of people's lives. So it's not that they're all bad. It's that there's, just like anything else, there's positives and there's not so positives with just about anything.
Right. Well, thank you so much.
Okay. Thank you, Hannah. It's been a pleasure. And I'm here if you have any further questions. You know how to get in touch with me.
I hope you enjoyed this episode of the Derm Club podcast. If you found the discussion today to be valuable, please subscribe and share. I look forward to seeing you in the next episode as we continue to delve into dermatology and skincare with the world experts.